I guess we shall talk about DKA in children. Let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today in this episode, we shall look at diabetic ketoacidosis in children. If you haven't yet subscribed to this channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a comment, drop a like, and let's go. So in the spirit of the new content that I'm going to be creating on my channel, I'm pretty much going to be introducing a segment before each and every lecture, which is known as a warm-up segment, where I will ask you a question. It may be from an Ask You Station extract, it may be from a single best answer, it may be from a true or false, it may be from an essay. Then of course I will give you the answer at the end of the video, so make sure that you watch the video till the end. So here's a single best answer. You can actually answer it and then I will give you the answer and then you can mark yourself in whether you were correct or wrong. So the following characteristics of diabetes mellitus are true except A. Dextrose given to a known diabetic patient in coma with unknown blood sugar may be life-saving. B. Sodium bicarbonate is administered as management of diabetic ketoacidosis. C. DKA is the most common first presentation in diabetes mellitus in children. D. Sugar is freely attached to hemoglobin A1C. So remember that this is pretty much a medical emergency and it's going to be associated with type 1 diabetes. It can also be seen with type 2 diabetes, but we're going to be focusing with type 1 diabetes because that's what's much more common in children. And it's obviously due to an absolute insulin deficiency. It's usually can present as the first manifestation of type 1 diabetes, especially in adolescents. And in diabetic ketoacidosis, you have this uncontrolled catabolism that's going to be associated with insulin deficiency, hyperglycemia, osmotic diuresis, and dehydration. Now, what's going to be characterizing diabetic ketoacidosis? Number one, you're going to have a high blood sugar, which is a blood glucose that's greater than 11.1. You have metabolic acidosis, which can be evidenced by bicarbonate concentration that's less than 15 millimoles per liter. You also have a venous pH that's less than 7.3. You have hyperketonemia, that's a concentration of the ketones in the blood that's greater than 3 millimoles. Ketonuria, that's a concentration of ketones in the urine that's greater than 2 plus on your standard urine dipstick. Of course, you are also going to have features of hypotension and features of dehydration. Now, remember that DKA can actually occur with absolute insulin deficiency. That's the type 1 type of insulin, type 1 type of diabetes rather, and relative insulin deficiency. That's the type 2 type of diabetes. And in patients with actually type 2 diabetes, it's a rare complication where they undergo certain stressors or when their body's undergoing certain amounts of stress, which could be metabolic, it could also be physiological stress. Now, here, remember that the glucose is not going to be entering into the cells. The problem in diabetes is that insulin is like the key to open the cells so the glucose can enter. Now, you have a lot of glucose, but this glucose is not entering into these cells. So it's like you're starving in the midst of plenty. Then, remember that DKA can present at any age, and it's most commonly going to be presenting in puberty. There are some precipitating factors like infections, bacterial infections, intercurrent infections like UTIs, Klebsiella pneumonia, even corona, accounting for 40%. Disruption of insulin treatment, For example, poor compliance with insulin, discontinuation of insulin, 25%. In some cases, it may be the first presentations on new onset diabetes and 15%. Others may be due to dehydration, excessive alcohol ingestion, which is quite common in adults, but of course, even adolescents these days are drinking. There may be some stressful conditions like trauma, surgery, myocardial infarction, which is not so common in the pediatric age group, or emotional crises. Some medications like corticosteroids, thiazide diuretics, and sympathomimetics can actually trigger DKA. And in 40% of the cases, the majority of the cases, we actually don't know. We can't really identify what had triggered this DKA. So what exactly is the pathophysiology? Here I want you to pay some close attention. Now remember that whatever is causing this trigger, it's putting the body under a certain amount of stress. Now, whenever there is increase in stress, it means that even the demands for insulin are going to increase. But remember that these demands for insulin cannot be met by the body because the pancreas is not going to be making the insulin. So what is the body going to do? It's going to produce this counter-regulatory hormone. Because remember, insulin is the key for glucose to enter into the cell. So the body will take it like as if you do not have glucose. So it will stimulate other processes that are meant to enhance the production of glucose and also use other alternative sources of energy. So what are these counter-regulatory hormones? Glucagon, cortisol, epinephrine, and growth hormone. Now remember that these hormones are going to be working in tandem to increase the blood glucose level. So they're going to inhibit processes that use up blood glucose. So they'll inhibit processes like the glycolysis. They'll inhibit processes like glycogenolysis, which is a breakdown of glycogen. They will stimulate processes like gluconeogenesis, which is the synthesis of glucose from non-carbohydrate precursors. They will inhibit breakdown of glycogen. Rather, if I mentioned about inhibiting breakdown of glycogen, it's actually stimulated. They inhibit the synthesis, which is glycogenesis. Correction on that. So they are also going to be stimulating the process of glycogenolysis, which is the breakdown of glycogen into glucose, as well as lipolysis, which is pretty much the breakdown of the triglycerides into free fatty acids and glycerol. Now, all these processes are going to be contributing to a high blood glucose level, which explains why when you check the blood glucose level, it will be higher than 11.1. Now remember that glucose in the cells is going to be filtered out in the kidneys. And under normal circumstances, all the glucose is supposed to be reabsorbed. But in this case, it's not going to be reabsorbed from the kidneys. So it will be lost in the urine because it will exceed its transport maximum. So this will now cause the renal tubule to become osmotic, hyperosmolar, because there's a lot of glucose in that area. So it's going to pull more water now. This person is going to be losing water in the urinary system, so they'll have polyuria. In addition to this, remember that the free fatty acids that you're forming in the blood are going to be taken to the liver, and then through a process that's known as beta oxidation, they're going to result in the synthesis of keto acids or ketones, which are pretty much alternative sources of fuel. Some important ketones include acetone, acetoacetate, and beta hydroxybutyric acid. Now, these can also be filtered out in the kidneys, and by the kidneys rather, and in the urine, when you test for these, you'll be able to see them on the urine. They can also be excreted in the lungs through the breath, such that this person will have this fruity breath. You can also test for these ketones in the blood, and this person will have these ketones in the blood. Now remember that because these are keto acids, they tend to drop the pH of the blood. So even the pH is going to be now becoming acidic. Now remember that the response of your blood being acidic due to metabolic causes is going to be compensated by the respiratory system. So the respiratory centers are going to be stimulated. How does the body think? It thinks that you're retaining a lot of carbon dioxide. So the respiratory centers are stimulated in an attempt to hyperventilate so that you can push out some carbon dioxide to compensate for the acidosis that you have created. So this is what is responsible for all the clinical features that we see in patients with diabetes. Now, because of the excessive loss of water through the hyperventilation, because every time you breathe out, you lose some water, through the increase in urine output, the polyuria, This person may present to you with some dehydration. They may also have additional things like nausea and vomiting, diarrhea that may also even worsen the dehydration. So I have already explained what is showing on the screen here. In addition, there is also going to be an increase in protein breakdown and a decrease in protein synthesis, because remember, insulin is an anabolic hormone, and its deficiency will lead the body to go into a catabolic state. Then, because now you also have accumulation of this acidic organic substances, the normal arterial pH will become acidic, and of course you will get an increase in an ion gap. I'll talk about what the anion gap is. Now, the bicarbonate levels in the blood are also going to drop because you're trying to buffer out this acidosis that you have created. Now, this person will have this rapid shallow breaths, or sometimes they can have this labored breathing, the air hunger. These rapid shallow breaths are referred to as Kussmaul's respirations. Now, they become much more severe, especially with increasing acidosis. The patient may also have vomiting and nausea, which is induced by, of course, the ketones. And I've talked about the fruity breath, and I've talked about the dehydration. Now, remember that because this person is severely dehydrated, blood is going to be shunted out to the vital organs, and sometimes to some extent the vital organs are also going to be affected. So this person may actually go into renal impairment or renal failure, which is why it's very important to actually look at the urine output of patients with DKA. Now, remember that when you have, in the initial phases, when you have acidosis, there is a special channel on red blood cells which is known as a potassium hydrogen exchanger, which pretty much takes in hydrogen ions and takes out potassium ions in order to balance that offset that you've created, that acidosis that you've created. So in the initial phases, you may actually have hyperkalemia, but as you treat this patient with insulin, because remember, glucose enters into the cells with potassium, again also because of the osmotic diuresis, they more or less may present to you with hypokalemia. So they can present to you with hyperkalemia or hypokalemia. So what are some of the clinical features? They may have a gradual increase in thirst, that's polydipsia. They may have polyuria, which are very common early signs. They may have features of dehydration, malaise, generalized weakness, fatigability, nausea and vomiting, which may be associated with diffuse abdominal pain that can actually be confused with an acute abdomen. Then you may also have decreased appetite and anorexia, a fruity breath, that's a ketone on the breath, acidotic breathing or hyperventilation, unexplained coma. Then, of course, there will be a history of rapid weight loss, especially in a newly diagnosed type 1 diabetes patient. Now, most children are going to be dying from hypokalemia or cerebral edema. Now, because cerebral edema is unpredictable, it occurs much more commonly in younger children and newly diabetics. And once they have cerebral edema, 80% of them will die. So it means if they develop cerebral edema, you have to manage that. So there will be some mental state changes. Some patients may be mentally alert at presentation, but they may be drowsy, lethargic, or confused. Sometimes they may even evolve into coma in 5% of the cases. They may be showing signs of dehydration, a dry tongue and buccal mucosa, poor skin turgor, hypotension, increase in heart rate. Of course, these are due to osmotic diuresis, the polydipsia, polyuria, nocturia. They may have Kussmaul's respiration, deep, fast breathing resulting from the metabolic acidosis. They may also be hyperventilating. It becomes less marked in very severe acidosis because they will even have some respiratory depression. So it doesn't mean that they're getting better. Then, of course, I've talked of the fruity breath. Now, how do we make a diagnosis? We require all three of them. If the person comes in, they are either a known diabetic patient or they have a blood glucose that's greater than 11. The urine dipstick, their ketones in their urine must be greater than 2 plus. The serum ketones must be greater than 3 plus or greater than 3 millimoles. Then, of course, your arterial blood gases will show a metabolic acidosis, a low bicarbonate concentration that's less than 15 millimoles, and a pH that's less than 7.3. Then other investigations that you may do, like urea and creatinine, they may be raised. Serum potassium, of course, it may be hypokalemic or hyperkalemic. Then, of course, your serum sodium, because of the osmotic effect of glucose in the urine, you lose a lot of glucose, and the serum sodium may actually even be low because you lose a lot of water, you lose a lot of electrolytes, especially sodium. Then there will be an increase in the iron-ion gap. Then you may order for other investigations that look for certain infections. So a complete blood count, liver function tests, urine microscopy culture sensitivity, and RDT for malaria or malaria parasite site, blood cultures, and arterial blood gases. Now, what exactly is this anion gap? It's just simply the difference between the measured cations and the measured anions, the routine measured cations and anions. You have sodium, potassium, chloride, and bicarbonate. So you add the concentration of sodium to the concentration of potassium minus the concentration of chloride plus the concentration of bicarbonate. So if you use potassium in the calculation, the normal is between around 16 plus or minus 4, meaning 12 to about 20. Then if you don't use potassium in the calculation, it's about 8 to 16. So this anion gap may be increased or decreased. It's often increased in metabolic acidosis. It's rare that you get a decrease in an ion gap unless if you're discharging some positively charged ions in the urine. For example, in proteins that you're actually losing in urine in multiple myeloma. Now, what are the principles of management? This is where it's very, very important because this has some difference as compared to management in adults. So you want to correct the dehydration, you want to correct the acidosis and reverse the ketosis, you want to restore the blood glucose to near normal, avoid any complications of therapy, identify and treat any precipitating events. Now, the management, you can use the mnemonic FIPA or SIPA. So F for fluids and electrolyte balance, the S, you can use it for solutions, I for insulin, P for potassium, and A for antibiotics if an infection is present. Now remember that children, the guidelines that I'm about to give you are pretty much assuming that this child has more than 5% dehydration, or they have been vomiting, or they are drowsy, or they are clinically acidotic. Now what's our general advice? You pretty much want to resuscitate the patient first before you do anything else. So check that the airway is patent. If they're comatose, insert an airway, and also if they've recently vomited, insert an NG tube, aspirate, and leave it open to drain. Give them oxygen 100%, and if they are becoming apneic, a bag and mask ventilation. Then, of course, circulation, gain IV access with 2 large bore cannulae, take bloods for the lab. Then, of course, if they're in shock, meaning that they're tachycardic with a poor capillary refill time, cold clammy skin, cold peripheries, and hypotensive, then you can give a bolus. You can give 10 to 20 mils per kg of normal saline quickly. So that's in about 1 to 2 hours. So I'll give you a practical examples. Let's suppose we're using 10 milligrams or 10 mils per kg and the child is weighing 20 kg. So it would be 10 multiplied by 20. So over 1 to 2 hours or 1 hour, they should receive about 200 mils of normal saline. We can, of course, repeat this up until we reach a maximum of 30 mils per kg. Then after you have resuscitated the child, take a history and confirm your diagnosis. So your history of polyuria and polydipsia, your clinical features of acidotic respirations, dehydration, drowsiness, abdominal pain, and even vomiting, your biochemical results of a high blood glucose, ketones in the urine, ketones in the blood, glycosuria and ketonuria. Assess the level of consciousness of this child using your Glasgow Coma scale, if of course they're above the age of 5, or a Blantyre Coma scale if they're younger than this. Then of course assess the level of dehydration, because this is very important when you're managing the fluids. Assess for any features of cerebral edema. Could be things like irritability, a slowed pulse, a high BP, and you should also perform a fundal examination that may show you papilloedema. Then strict input-output charts. So if the child cannot void on demand, or the person is unconscious, so it's a very young child, catheterize the patient. Monitor their blood sugar hourly. Weigh the patient. Don't use whatever has been recorded before in the other reviews. Weigh the patient currently, because you use this for the calculation. Then open a Glasgow Coma scale chart or a Blantyre Coma scale chart, and of course ECG monitoring. So we'll begin with the fluids. Remember FIPA, fluids, insulin, potassium, antibiotics. So you want to begin the fluid replacement before the insulin. So the fluid should be given at least 1 to 2 hours before the insulin. Now remember that in DKA in adults, we were given this fluid quite copious in like 24 hours in a patient that presents with DKA, an adult with DKA. We don't do that in children because the child is going to be overloaded with fluid, so we don't do that here. So the fluid bolus can actually be given to resuscitate this child and to restore the peripheral circulation, and we don't usually even consider it when we're calculating this fluid replacement that we're going to be giving. Now, these fluids, whether you're giving them IV and then you transition them to oral, aim to give them evenly over 48 hours. Now, how are you going to do this? How much fluid does this child require? So you say your maintenance plus your deficit. Now, remember, you're going to be assessing this child for those signs of dehydration. So when you assess the child for the signs of dehydration, remember, you could have no dehydration, some dehydration, or severe dehydration. No dehydration meaning that they have lost less than 5% of their body weight. Some dehydration meaning that they've lost 5 to 10% of their body weight. Some books even give you 5 to 7. Some severe dehydration, they've lost more than 10%. So some guidelines give you 7 to 10%. Now, how do we calculate the deficit? We say the percentage of dehydration. For example, if the child has some features of dehydration, you would say, for example, 7%, or for easy sake, 10% multiplied by their body weight. I'll give you an example in the next slide. Then, of course, the maintenance is calculated 100 mils per kg for the first 10 kg, 50 mils per kg for the next 10 kg, and 20 mils per kg for every kg after that. For example, if a child weighs 25 kilograms, in 25 you can split it into the first 10, the second 10 to give you 20, and the remainder will be 5. So 10 multiplied by 100 plus 50 multiplied by 10 plus 20 multiplied by 5. That's what I mean by 100 mils for the first 10 kg, 50 mils per kg for the next 10 kg, and 20 mils per kg for every kg thereafter. That's the maintenance. So you calculate your deficit, you add it to the maintenance. Then, of course, this is what you will give in 24 hours. Then remember that after 24 hours, you go to 48 hours. In the next 24 hours, you're not going to give the deficit again. You're going to give another maintenance dose. So you just simply say, the maintenance, multiply that by 2, or you can add the maintenance twice plus your deficit. That's how much you should give over 48 hours. I'll give you a practical example in the next slide. Some people can even give it over 36 hours. Now, remember that your fluid of choice is normal saline. You can actually use Ringer's lactate if you don't have normal saline, but normal saline is advised. Then, of course, you should change to DNS once your RBS has fallen to 12 millimoles. Others use a threshold of 14 to 17 millimoles. Then if they have hypernatremia, then you can use half-strength normal saline, but please make sure that you consult with your senior first. Here's a practical example. Suppose a 25 kg diabetic patient presents with DKA and severe dehydration. Remember, in severe dehydration, they've lost 10% of their body weight. So 10% of 25 is 2.5 liters. So they've lost about 2.5 liters. That's roughly 2,500 mils. So this is our deficit, our 2,500 mils. This is our deficit. Now, what's the maintenance of this child over 24 hours? This is 25 kg. So 100 mils for the first 10 kg, 50 mils for the next 10 kg, 20 mils for everything that is remaining. So this gives you 1,000, this gives you 500, this gives you 100. So 1,000 plus 500 plus 100 gives you 1,600. So they should receive 1,600 maintenance in addition to this deficit that they have created. But remember that we want to give this over 48 hours. So it means that the maintenance must be given twice, for the first 24 hours and for the next 24 hours. So the deficit plus the first maintenance in that 24 hours when the child reported, and the next 24 hours. That will give us a total of 5,700 mils over 48 hours. But you're not going to be flushing this continuously at once in this child, no, because they will be overloaded. So you want to give it in small, equal portions. So if you're giving 5,700 mils over 48 hours, how much should you give in 24 hours? You divide that by 2, because 24 hours, 48 hours, you divide that by 2. So 5,700 divided by 2, it means that in each 24 hours, this child should receive a total of 2,850. Okay? Then now, remember, we're not going to be giving this again over 24 hours, but we want to now give it into a smaller portion. We give it every 8 hourly or every 6 hours. So if we're giving 2,850 in 24 hours. How much will we give in 8 hours? You simply just divide this by 3. So you get 950 mils every 8 hours. You can even further divide this now by 8 to see how much you should be giving every hour. Then, if you're giving it 6 hourly, you can divide this value, 2,850, by 4. So that gives you about 712.5 mils every 8 hours. You can either round this or you can just give 710 mils every 6 hours. That's how we give the fluids in DKA in children. I really hope you understood that. If you didn't, just rewind the video and go through it slowly. It should make sense. And of course, the next thing that we do is giving insulin, which is usually started 1 to 2 hours after the treatment. So we use our short-acting insulin, soluble preferably. So this can be given at 0.1 international units per kg per hour as a continuous infusion. One method in which we can do this is we get 50 units of regular insulin diluted in 50 mils of normal saline, such that every mil that you give is equals to 1 unit. So if we are actually giving or actually looking at the child that we had, if we're saying 25 kg multiplied by 0.1, so this child should be receiving about 2.5 units of insulin every hour. So it means that in 2 hours they should have received 4 units. So that's about 4 mils of this infusion. So it should run very slowly. You can actually calculate how many drops this is going to be for you to now reach the 4 units in 2 hours, or the 2.5 units, or rather, the 2.5 units in 1 hour, or the 5 units in 2 hours, depending on however it is. The calculation is very simple. I think I did calculations on my fluid video on how to do the drops per minute. Then an initial bolus is not needed for this because it is increasing the risk of cerebral edema. Then in younger children and those that are sensitive to insulin, give a dose of 0.05 units per kg per hour, provided that the metabolic acidosis is resolving and the blood glucose is dropping. You want to aim to drop the blood glucose between 2 to 5 millimoles per liter per hour. It should not exceed 5 millimoles per liter per hour, because if it exceeds this, then it's dropping too quickly. The child can easily go into hypoglycemia. And remember that hypoglycemia will definitely kill you. Hyperglycemia may take some time to kill you, but hypoglycemia kills much quicker. And of course, if you can't have a continuous insulin infusion, you can give it hourly or 2 hourly subcutaneous or IM, short or rapidly acting insulin. Now, given that you have restored the peripheral circulation after you've given your boluses, now you give an initial dose of subcutaneous insulin, 0.3 units per kg, followed 1 hour later by 0.1 units per kg per hour. Or you can give 0.15 to 0.2 units every 2 hours. Then, of course, when the blood glucose is less than 14, we half the dose. We now give 0.05 units per kg per hour to keep the blood glucose around 11 millimoles per liter. Now, if the blood glucose drops too quickly or too low before the DKA has resolved, you don't decrease the insulin infusion, but rather you just give them much more glucose. Then the next is potassium. So if the potassium is greater than 6 milliequivalents per liter, you don't give any potassium chloride. If you see any peaked T waves on the ECG of the patient is anuric, catheterize them and wait for some urine output. Do not give potassium chloride. Then, of course, if the potassium is between 4.5 to 6 milliequivalents per liter, you can give 10 millimoles of potassium chloride. If it's between 3 to 4.5, you can give 20 millimoles of potassium chloride. You should monitor the levels of potassium and stop the infusion if it's greater than 5 milliequivalents per liter. Of course, continue monitoring even after the infusion is stopped in anticipation of any recurrence of hypokalemia. Potassium should be added to every 500 ml of IV fluids given for the first 24 hours. And of course, ensure that the patient doesn't have any acute kidney injury and the patient has passed urine, which is very important why you must catheterize this patient. Bicarbonate is not routinely given in children because it's going to be associated with cerebral edema. Now, antibiotics can be given, and this must be based on the culture and sensitivity patterns. For patients that are febrile, you give them antibiotics. So it's not always indicated, but in most of the cases, we realize that there is a focus of infection. For example, if the glucose is not dropping, you have done everything right, you have given the fluids, you have given the insulin, and the glucose is not dropping, then you should suspect other causes like septicemia or sepsis, and you should cover them on antibiotics. Then, of course, there will be a time where you want to switch them to oral fluids and transition them to subcutaneous insulin injection. So this is done once there is substantial clinical improvement, where they can either be mild acidosis or ketosis that may still be present, or you now want to switch them to giving them the insulin before mealtime. For example, your regular insulin subcutaneous 0.25 units per kg before every meal, before breakfast, before lunch, before dinner. Then you give the intermediate acting insulin before bedtime. Then, of course, the total insulin dose is about 1 unit per kg per day. Then, of course, to prevent the rebound hyperglycemia in the first insulin injection, then you should at least wait 30 minutes if you're using rapidly acting insulin, or 1 to 2 hours if you're using regular insulin, before stopping the insulin infusion, so that you give time for the insulin that you're given subcutaneously to be absorbed and to start working. And of course, the dose of the insulin can be titrated against the capillary blood glucose. Eventually, you convert them to a long-term insulin regimen when they're stabilized, something that you're going to discharge them on. We'll talk about this later when we talk about diabetes in children. There are some related complications just to conclude this lecture. You may have things like hypotension, coma, cerebral edema, hypothermia, hypophosphatemia, pneumonias, aspiration pneumonia, DVTs. There may be some complications associated with therapy such as hypoglycemia, hypokalemia, hyperkalemia, pulmonary edema, as well as hyperchloremic acidosis. Now, getting back to our warm-up question. So the following characteristics of diabetes mellitus are true except. So dextrose is given to a known diabetic patient in coma with unknown blood sugar may be life-saving. This is true. If you don't have the facilities to check the blood glucose of this patient, we always assume that they're hypoglycemic, because hypoglycemia would definitely kill you faster than hyperglycemia. Then, of course, DKA is indeed the most common first presentation, and the sugar does freely bind to hemoglobin A1C. But sodium bicarbonate is not administered. So the answer which is incorrect here is B. Sodium bicarbonate is to be administered as management of DKA, or diabetic ketoacidosis. That's not true. I really hope you enjoyed this video. If you did, please drop a like and drop a comment. Share the link to someone who is doing pediatrics. My name is Dr. Moses Kazevu, to Zambia and beyond. Until next time, bye-bye.